All right, so we are just going to cover a very short section, and that is the use of laboratory tests in infectious diseases. Um, Once we cover that, I think we should be good to go. So let me just share my screen. There you go. So please confirm that you can hear me.
Yes, we can.
Okay. All right. So we are basically talking about laboratory tests in infectious diseases, and this includes especially respiratory infectious diseases. These are a short topic, but also keeping in mind that you have come across most of these tests. So we are saying that we need timely and accurate diagnosis. That is the very first step in ensuring that you manage properly. Many times, people have misdiagnosed infectious diseases, and in the process, people have ended up with very severe infections when you miss the diagnosis. So we need our laboratory tests to ensure that we don't miss out, we don't misdiagnose an infectious disease. Remember, the more the delay of starting treatment, the more the morbidity, the more the chances of mortality, and therefore we want to start as early as we can. So traditionally, we just these are still the gold standards in terms of diagnosis. However, as we know, before you get your culture results, this is very, very time consuming, and yet your patient is there, requires prompt and therefore we have to think about what are the tests that we have that can indicate to us whether we are dealing with an infectious disease. So so we do have body fluid biomarkers, and these body fluid biomarkers are easily obtainable, and they are good for showing us whether we do have an infectious disease. Some of these biomarkers that we can test includes a leukocyte count as you're doing your full hemogram, includes procalcitonin, C-reactive protein. These are the main three laboratory tests that we require for community-acquired pneumonia. However, they are not perfect. Okay, they are what is. This is what we have, but they are not perfect. So sometimes you can have high levels of these for say for a viral infection, yet you're looking at a bacterial infection. So these are some, let's start with the leukocyte count. Look at the normal ranges there. Look at them, they are different, yeah? So depending on the age, so which of these groups has the highest leukocyte count? Is it the adults or is it the neonates?
Neonates.
Yeah, the neonates. The neonates have a very high leukocyte count, and therefore, even if you receive a high leukocyte count of 27,000 for a neonate, you should not flag it as an infection. You should know their range. Okay. So, so the leukocyte count is further divided into neutrophils. Are they neutrophils? Are they lymphocytes, monocytes, eosinophils, and basophils? Again, each of these has their normal ranges. The moment you have exceeded ranges, for example, of neutrophils, then you are likely to be dealing with a bacterial infection. The moment you have a very high lymphocyte count, you are probably dealing with a viral infection. So the moment you have a very high eosinophil count, you're probably dealing with a parasitic or an inflammatory reaction. So the cell count, the leukocyte particular cell count, so all these are leukocytes, but each cell will kind of indicate you to the probable infection. So that is why we separate them. So if you look at your hemogram, you'll be able to see that you have the general WBC count, but on top of that, you'll see several differential counts, counts of lymphocytes, neutrophils, monocytes, and the others. So if you see an elevated WBC, it is not automatic that it is infections. Even stress and other inflammatory disorders can cause an elevated WBC. So again, you have to look at the clinical picture. What is the clinical picture? So that you don't just treat everybody based on a increased WBC. So anytime you have high elevated WBC count, and on top of that you have weakness, malaise, chills, and fever, then you're likely to be dealing with an infection. So the clinical picture needs to go hand in hand with the laboratory picture. Again, we say we do not treat lab results. So you should have a clinical picture that correlates with what you have on the lab. So if your lab is not correlating, then you probably need to do the test properly. Consider that you have done your proper test or repeat the test because they should not differ. Or you have a missed diagnosis. So anytime you have your neutrophils greater than 7.5 times 10 to power 9, then that is leukocytosis. Okay, when the neutrophils are more than 7.5. This is a reflection of an acute bacterial infection. So you can see why a hemogram is so essential. You can see here our neutrophils, the higher range is 8,000, but by the time you're at 7,500 going up, then you are likely to be having an acute bacterial infection. Um, for the eosinophil count, when you have eosinophils greater than 0.4 times 10 to power 9, yeah? Let's go back to here. You can see here our cells are 550 to 500. So anytime you have 0.4 times 10 to power 9 greater than, then you're likely to be dealing with an allergic disorder, especially asthma or hay fever. You're likely to be dealing with parasitic infections or even drug reactions. So again, you have to check on that. For the basophils, and reactions that could be IgE mediated. So you can see why the hemogram does not just show us a high WBC count, it also shows us which particular cells, yeah, which particular cells are problematic. Okay, so again, for the monocytes, you have monocytosis, or when you have 0 greater than 0.8 times 10 to the power 9 per liter. when you have that number of cells. And some of the causes of high monocyte levels includes TB infections, bacterial endocarditis, rickettsia infections, malaria, and collagen vascular disease. Okay, and even inflammatory bowel disease. All these are probable causes of monocytosis. Again, let's go to the lymphocytes. A high lymphocyte count of greater than 3.5 times 10 to power 9. Um, these are indicators of viral infections, and this is very, very, very useful. Anytime you see a high lymphocyte count, remember if you get a pneumonia and you can tell there are signs of an infection, there's fever, the clinical picture, the difficulty in breathing, the malaise, the chills, yeah, and the crackles in the lungs. Now the next question is it bacterial or is it viral? That's the question you have to answer. And therefore, one of the reliable things to consider is the lymphocyte count. If it is greater than 3.5 times 10 to power 9, consider it a viral infection. And that becomes very useful even in terms of deciding what antibiotics to put the patients on. So sometimes cancers can cause multiplication of these white blood cells, yeah, so that you have abnormal clones of white blood cells in the bone marrow that are multiplying, and therefore you can have lymphoid and myeloid neoplasms, yeah. So again, if you have too much proliferation, you need a peripheral blood film to check what kind of cells are being released. But at the same time, you also need a bone marrow aspirate to check what type of cells are being released into the bloodstream. The other biomarker is procalcitonin. This is a very, very useful biomarker. Okay, it is a member of the calcitonin superfamily. Is very critical, especially in the ICU setting. If you want to distinguish between bacterial and viral infections, this is one of your most reliable biomarkers. Yeah. Um, so a rapid elevation indicator of a bacterial. This becomes very useful because in an outpatient setting where you really need to determine whether I'm going to give antibiotics or not, then procalcitonin becomes a useful measure. For some reason, it's not routinely done, but it's so good because you're able to actually determine that what you're dealing with is a bacterial infection, is not a viral infection. So procalcitonin becomes useful because it is more specific. Tests like ESR used to be done a lot in the past. I think some of you might remember this ESR. However, the problem with ESR is not specific. Yes, you can do it to show inflammation, but you don't know what kind of inflammation that you're dealing with. Yeah? Is it a bacterial infection? Is it an autoimmune reaction? You are really not certain. So ESR for long has been used as a sickness indicator, but even then it does not provide any extra details of what type, what is it an autoimmune, is it an infection, is it bacterial or viral? The ESR is unable to show you. So it's not specific, and as you can see, it is used as a sickness indicator in quotes, yeah, because it's just an indicator, but it's not specific at all. So if you were to actually ask, how do I differentiate between viral and bacterial infections, then one of your go-to tests would be which one? For those who are still present now, what would be your go-to test?
Calcitonin.
Procalcitonin, yeah. Okay, procalcitonin becomes your very, very important test. So I was about to go to, I don't know where. Oh yeah, this is what I skipped. So we do have this biomarker. This is a very common biomarker. It's called a C-reactive protein. This is a protein that is synthesized by the liver. And anytime there is some acute inflammation, the protein level rises. Yeah. So it's an acute phase reactant protein, and therefore it can be used very well in the early phases of an infectious process. So if you want to know, okay, maybe you have an exposure to a certain infection, and you want to tell, okay, do I need to treat, especially for example, newborns? Yeah, a newborn has been born to a mother with a certain infection. So you are wondering now, should I put this newborn on antibiotics? What do I do? So one of your best tests is the C-reactive proteins, because quickly it can tell you that we actually already have an infection. It is an acute phase reactant. Within few hours, you can tell whether there is an infection or there isn't an infection. So it's also a beneficial. However, it is not specific. It cannot differentiate between bacterial and viral. So we are still we use it, but we don't rely on it so entirely. But I know there are many facilities that you do a lot of CRPs, and that's still fine. Okay, so any questions on the lab test? Okay, so please don't forget, we have C-reactive protein, we have procalcitonin, we have the leukocyte counts, we have the differential counts. All of those are very important. So let me confirm that we are still together now that there is no question from the room. Yes, indicate on the screen on a reaction that we are still together. Okay, good, fantastic.
Yes, yeah, together.
All right. Yes. So let's do this very short also, in about 15 or so minutes. Then we can head out for preparation for tomorrow. So let me put this up. So I had mentioned to you that in as much as I shared with you the ones that you'll do on your own, I really wanted us to cover this together, the cystic fibrosis, and then the rest you can do on your own. So cystic fibrosis is a disease of the exocrine gland function. Okay. And now, unfortunately, being a disease of the exocrine gland, it causes it to involve many organ systems. But the most affected is the respiratory system. Others that are affected includes a lack of pancreatic enzyme, yeah, and because of that, associated complications. So in most of the patients, up to 90% of patients, they have a pulmonary involvement, yeah. And for most of them, the principal cause of death is end-stage lung disease. So, how do you diagnose cystic fibrosis? You diagnose cystic fibrosis based on the number one, the symptoms that that are there, and especially pulmonary symptoms, GI tract manifestations, which we shall see, a positive family history of the same, of cystic fibrosis, and if you do your chloride, your sweat chloride test results, they turn positive. So we shall relook at that, all those 4 points again. So because of the way cystic fibrosis can affect several organs, yeah, then we need a lot of complexity, and in terms of managing these patients. You have to look at their GI manifestations, you have to look at their respiratory, you have to look at all other functions that are affected by cystic fibrosis. So when you work with cystic fibrosis, what's known is cystic fibrosis, it is actually a genetic condition. Cystic fibrosis is a genetic condition, and what cystic fibrosis does, um, it causes the gene, what we call CFTR, the gene CFTR, yeah, that is a chloride channel and is regulated by cyclic AMP. So this gene is what is defective. It codes for the chloride channel. Anytime you hear chloride, you hear sodium, you hear water. Okay. So when you have a defective CFTR protein, you have abnormal chloride transport across the cells and surfaces. And if you have abnormal movement of chloride, what goes with chloride? Sodium goes with chloride, and water goes with sodium chloride. Yeah. So you can see if you have a defective gene, the CFTR gene, then you can have a lot of problems. Yeah. Um, so what happens is that this results in a lot of dehydration of the epithelial linings, a lot of dehydration of the epithelial linings, and because of that, their chances of infection become very, very high. So anytime that the epithelial linings cannot be um, uh, um, moistened, and therefore they are dried up, yeah, then the chances of infections are so, so, so high. So these patients present with secretions in the respiratory tract, yeah, in the pancreas, GI tract, sweat glands, and other exocrine tissues. So we are going to see them actually. So what we are saying is that we are not able to move the water. We are not able to move water into our epithelial linings. And because the water is not moving to epithelial linings, the surfaces become dry, they become prone to infections. The surfaces become difficult to, if you have mucus, it's difficult to clear. So you find that there's no movement, yeah, and therefore the chances of infections are increased drastically. So if you are looking at the respiratory system, yeah, you want the patients to be able to clear the mucus. But now when you don't have water, these secretions are very, very viscous. They don't have water, and therefore they become very difficult to clear. They become difficult to clear, and because they are difficult to clear, then you start having infections. Yeah, you start having all kinds of challenges. So when you have such a genetic problem shortly after birth, so remember it is genetic. So shortly after birth, you'll find that these patients, these babies, these newborns have a lung infection. When they have a lung infection, it incites an inflammatory response. Okay, and then you have an inflammatory response. And then the more fluid is being produced, it is viscous, it is dry, and the cycle continues. So these patients are always in and out of hospitals because of infections, yeah, because of the challenges in their respiratory system. So, however, if you manage them well, at least 80% of them should reach adulthood, but it is a life limiting disease, and we still do not have a cure for it in terms of a medical cure for it. So, what determines the outcome is the extent of pulmonary disease. It is the pulmonary disease that is the determinant of how will the outcome be. So, um, remember this pulmonary involvement might just include bronchitis, bronchiolitis, then finally bronchiectasis, and may even lead to right sided heart failure and end stage lung disease. So, entirely, we are dealing here with a respiratory failure. You have heavy viscous secretions in the chest, you don't have proper gaseous exchange, and eventually you compromise the lungs, and therefore, even the heart compensates, and that's why we end up with copulmonale or right sided heart failure. So, again, what are our systems that are affected? The GI symptoms. You have the urogenital tract, the respiratory tract, and you can have a multi system involvement of several organs. So, but as for the respiratory tract manifestations, patients usually come with a recurrent cough that is unending, a chronic cough, and it can either be dry or it can produce sputum. So in infants, you can have prolonged symptoms of bronchiolitis. So usually bronchiolitis should clear within 2 weeks, but then you have prolonged symptoms. That means there is too much mucus and the body is unable to clear it. Yeah, that is a respiratory tract manifestation. Paroxysmal cough, where you have bouts of cough that can be followed by vomiting, recurrent wheezing, and dyspnea. Definitely, we have difficulty in breathing in those patients. So, remember, we said our main problem is the CFTR gene, and the CFTR gene codes for the chloride channel. So, when we have a defective CFTR gene, our problem will be at the chloride channel. Yeah, and therefore, because of that, when we are testing for cystic fibrosis, you need to have at least the clinical backing. But what will help you to determine is actually a positive sweat test result. Yeah, a positive sweat test result, and what they look for is the chloride ions. Yeah. So that is one. Number two, typical COPD. So this patient will always be like the other COPDs, always having issues with their respiratory from birth. Yeah, so do not mix them up with COPDs. These are patients with a genetic problem. So again, they do have pancreatic insufficiency, yeah, and a positive family history. That means that within the family, they can actually trace a person who had a similar problem. So, what are our goals in cystic fibrosis management? We want to maintain the lung function as near to normal as possible. We want to make sure that we have proper nutritional therapy, and we want to manage complications. So, how do we do this? In acute cystic fibrosis, you have to make sure the airway is clear. You might require some inhaled bronchodilator treatments. And one of the most helpful things is chest filtration. physical therapy so that they are able to activate the chest so that it can remove the excessive mucus. So chest physiotherapy becomes a very, very useful tool for these patients. So again, in an exacerbation, you might need to consider the dose of the mucolytic agent. Why do we need a mucolytic agent? Because you have the excretions are so viscous, so heavy. So if you add a mucolytic agent, then you're able to break down the mucus. Also, remember what we said about infections. You might actually require antibiotics. So, what enzymes do we use? Or rather, what medications do we use? We need pancreatic enzyme supplements. Remember, we said how, let me come back to this. We talked about GI tract manifestations, yeah? And so I want to come back to this, yes. So you have secretions in the respiratory tract, they are viscous, but also in the pancreas, yeah, in the GI tract, all those secretions are viscous and therefore they are not even moving as they should. That means that essentially these secretions that are supposed to contain enzymes, yeah, they are lacking. So what do you need to supplement? You need to supplement these pancreatic enzymes because they are lacking. Yeah, you need multivitamins. You need mucolytics to break down the mucus. You need your antibiotics. Remember, we said how the chances of infection are high. You need your bronchodilators. You need your anti-inflammatory agents. And then we have these agents that are actually being shown to reverse the chloride transport challenges or the transport problems. Drugs like ivacaftor, lumacaftor, yeah, tezacaftor, ivacaftor. So these drugs have been shown to reverse the chloride transport abnormality. So these are drugs that we can also consider. Does any one of us stock any of these drugs? If you don't, you can put a thumbs down. Do you guys stock these products there? Ivacaftor, lumacaftor. Okay. Okay, so it's not a. Oh yeah, there's somebody whose talks. All right, I'm hoping it was the accurate. Somebody's laughing, so I was hoping that it is an accurate representation of your facility. Anyway, let's go back
Doctor, I
here.
have a question. I have a
Yes, yes.
question.
Go
What
ahead,
are
go
the
ahead.
examples of pancreatic, an example of pancreatic enzyme supplements?
These are. I don't know. I don't know whether we really stock these, but they are actually available. The gastroenterologists usually give them. Remember, we can also have resections of the pancreas, and therefore some of the patients might require pancreatic enzyme supplements. I have not come across them myself. I have not come across them, but they are there in the market. Um, I don't know whether maybe any one of us has stocked any of them, but they actually usually have the whole package. They have lipases, proteases, amylase. They help to do the whole digestion. Yeah, so they're usually there, but to be honest, I'm not interfaced with them myself. Is there anyone who has them, especially those people who do healthy pharmacies, um, these pharmacies that have a lot of branding for, natural health products. But they are there, yeah. So the thing is, they have lipases, amylase, or the whole band of the pancreatic enzymes. So I can't see anyone in the room with them. Okay, 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 Nancy. All right. So where were we? So we also need our agents to treat any complications that could be there if you're not having proper digestion. Yeah. Um, and as well, we have said we need drugs that have been said to reverse the chloride channel functionality. And we mentioned the several drugs, ivacaftor, lumacaftor, tezacaftor. Um, all right, so why do we need bronchodilators? Yeah, we need some smooth muscle relaxation. And also, if you want to clear the airway, just before you do your physiotherapy, open up the bronchioles a bit with the bronchodilators and then now do the chest physio, and then you'll have a lot of clearance of the mucus. So bronchodilators are useful to open up the airway, and then after that, then you are able to do your chest physiotherapy to ensure more clearance of the mucus secretions. Then we have mucolytics. Yeah, mucolytics. So for all the patients who are 6 years and below, we actually just use hypertonic saline. Yeah, hypertonic saline is usually adequate, and I believe that most of us have dispensed or come across the hypertonic saline. It is even what we use in pediatrics, not only for cystic fibrosis, but even for bronchiolitis, infections. We use hypertonic saline. However, we can also have other drugs. You can see a drug there called Donase Alpha. This one cleaves and breaks down the mucus and depolymerizes the DNA, separates the DNA, and this enables and allows the enzymes to break down the protein. So when you break down these mucus particles, now the enzymes can work on them. Yeah. So what are you trying to do? You're trying to reduce the viscosity. You're trying to break down so that the enzymes can interface with them. Then you have antibiotics. So essential, we saw why. If you have viscous secretions, they are not being removed, they are not coming out, they cause bacteria to settle on them, and they can cause really bad infections. Yeah. So for antibiotics, it depends on the culture results. So what bag has affected the patient? Yeah. And you go according to the culture result, you follow, and you give the right antibiotic. Okay, so you can see some examples of antibiotics. I do not want to specify which one, but you can know that you use the culture results. Yeah, so if the culture results indicate you need a fluoroquinolone levofloxacin, then you take that one, you choose that one. If the culture results show staphylococci or H influenza, then you know what that you prefer to have the cephalosporin. So on top of that, we still need a proper diet. We need a proper diet for these patients. However, they need more energy intake. Yeah, more energy intake. So they actually need a high energy and a high fat diet, as well as the vitamins as well. So why are we doing this? Because we probably have some malabsorption, yeah, digestion was maybe compromised, and therefore we need to cater for this so that you don't have a situation where you know you have, yes, the food, someone is taking food but you don't have enzymes to digest. Yeah, in fact, these patients actually benefit from direct supplements. Yeah, direct supplements, they actually benefit from some types of products such as um, actually, some of them, depending on the level of malnutrition, may actually find themselves requiring TPN, but we usually hope that we do not get there because of malabsorption. And therefore, we have to optimize our diet, ensure there's a lot of fat intake because the enzymes are not working as usual, the lipase is not working as usual, and therefore, you have to optimize the intake so that whatever is able to be worked on can provide some fat supply to the body. So, in terms of long term monitoring, you need to monitor your growth and development, your lung function. You need to monitor the lung disease, ensure you don't have an infection, ensure the GI system involvement is checked, yeah, and also check for complications. So I think we can stop there. I'm sending this to you on your emails. Is there any question on cystic fibrosis? Okay, are we good? Okay.
Yeah, good, Doc. Thank you so much.
All right. So I think we can stop there for today. Um, then we can continue next time. I know Hussein was mentioning tomorrow, but I'm not sure about tomorrow. I think we'll communicate. Let's communicate. So have a lovely night. I will share the notes with you.